This is hematology review. This is a little bit of heme, mainly anemia is clotting, and a little bit of onc, but not too much, because this is what would a primary care PA need to know, right? That's what the boards are heading for. So this is my email. You've got me on the internet either which way. So let's go. A lot of ground to cover. I have nothing to disclose. I do work for food, especially barbecue. And I do promote giving blood. Give blood, because it's the gift of life. Okay, these are all the objectives. We're going to hit on everything. So this is right off the NCCPA blueprint. So blood, again, your three cells that you got to worry about. Again, the red cell, the white cell, and the platelet. All of them have a purpose. Again, we have plasma. That's the major part of the fluid of the blood. It's got all your, basically water, but then you have your electrolytes, your proteins, everything. We won't talk a lot about that, but then there's a little bit of white, 1% white cells and platelets. They're not a lot of them, but they're highly important, right? And then the red cell, that's your oxygen carrying capacity, your buffer system, that's 45%. So that's the thing we'll start out with is red cells get low, you don't go. All right, white cells. They fight infections. They actually use the supertubing highway of your vascular system to get to a hot spot. Then they leak. Okay, they go out in the tissue and eat bacteria or invasion. So they marginate, and we want them to. We want them to get to a hot spot and go out and eat bacteria. Now, if a red cell does that, what's that called? That's bleeding. That's bad. Okay, so white cells can leave, red cells no. White cells are made in your bone marrow. And there's different flavors of white cells. So whenever your white count is high or low, it's best to get what's called a white cell differential. And it tells you the percentage of the different types. Neutrophils are predominantly the main, and they go up mainly in bacterial infections as a general rule. The band is a teenage juvenile segmented neutrophil just squirted out of the marrow. And it gets mature in about a day. But if you see a high band count, that's called shift to the left. It's not political, it just means they're juvenile, teenagers. And when you see a high band count, you're thinking your body's been very much invaded and it's responding appropriately. And that's like rut-row. You worry about like grabbing Mega Godzilla and culture everything. But shift to the left just means you're being invaded acutely. So the lymphocytes go up in everything viral, which is most of the world, right? Monocytes, they go up in a disease called mono. Okay, you've heard of mono before, Epstein-Barr viruses. But they're good clues for chronic infections like TB or subacute bacterial endocarditis. So you may see a mono smoldering. Eosinophils, the pretty red white cell, goes up in allergies primarily, but also parasites on board. Those are two clues for you. The basophil is a precursor to the mast cell. It goes up in allergies, but not as much as the EO. And otherwise, if you see a high basophilia, that's weird. What do you do with weird? Punt. That means punt to hematology. They'll probably do a bone marrow biopsy and see what's going on. Atypical lymphs, they look almost leukemic, but that means probably mono. That's more likely what you'll see in mononucleosis, and they're just big, kind of nucleated lymphocytes. So that's good to know, and especially you see the white count from 4.5 to 11 is kind of the range. So what do you do if they're low? That's called leukopenia, and viruses can do that. They can suppress the marrow. Chemotherapy, again, and radiation all suppress marrow. And we worry about Myledysplastic Syndrome. That's where most either two cell lines go low, red count and white count, and or platelet goes down. But that's telling you the marrow's being just not producing like it should. And then neutropenia, which would be your neutrophils are low, you're high risk for getting bacterial invasion. So anybody on chemo, that's a high risk thing to do. But neutropenic, we worry about invasion, right? Infection. And then we have the African American benign ethnic neutropenia. I saw this a lot at Grady in our population. It's just a chronically low, maybe between 3.5 and 4.5. But it's benign. It's totally just part of the genetics and population. So you got to know your patient's normals. and really before you call something low, and know what your population normals are. So just good to know. And then let's see, next. Oops. There we go. Myledysplastic syndrome. This was on the blueprint. And again, it can be anemia, thrombocytopenia, and or neutropenia on your CBC. It may have pancytopenia. Pan means everything. So if white cells, red cells, and platelets are low, where are you going to go? Bone marrow. Do you hear the rhyme? Okay. All 3 cell lines being low is kind of ominous. That says something's really wrong with the factory. All 3 cells are made in the factory, so that's a big deal. And that's usually punt to a hematologist. They're going to do bone marrow biopsies, try to figure out what's going on at the marrow level. But this is, again, this needs bone marrow biopsy, hemonc referral for supportive therapy. They may need transfusion support, and it may be a precursor to leukemia. So this is all something to, again, this primary care would be to recognize the cytopenias and then get them to a hematologist, see what's going on. Platelets are your friend. They're your plugger uppers, right? When you get a hole, platelets are there to plug it up. They do help the clotting cascade, but it's your first line of defense against bleeding out. So yes, you want the right amount, and you want them to work right. 2 things to think about. They're made in your bone marrow. All right, the red cell, hero of the day, carries oxygen, breathe in, oxygenate, breathe out, carbon dioxide, feed the trees. Normally, the happy life of a red cell is about 120 days as it circulates, as if everything's normal. It's a major buffer for your whole body system to keep your pH within normal range. Inside is the protein hemoglobin doing all the work. The red cell is just a fluid-filled floppy taxicab that carries hemoglobin that's doing all the work of binding and releasing oxygen. You got to have a little iron, folate, B12 to make your red cells and make your hemoglobin, and it's all done in the bone marrow. That's what a red cell looks like from a microscope. It's not a hole in the middle, it's a biconcave disc, so that red cell can flow through tight spots in your body. So there's a red cell in a capillary, that long stick is a red cell going out to your pinky, because your pinky wants some oxygen, right? So the red cell is very flexible. It can bend, elongate, go around curves. What happens if a red cell gets rigid? It ain't going in that capillary. You get lysis or hemolysis, and classic would be sickle cell. See, I'll wear my sickle tie for you. I've got sickling red cell. Anyway, yeah, you can look up close. Okay, moving right along. All right, well, hemoglobin's doing all the work. So really, it's your hemoglobin amount that really does the oxygen carrying, and basically that's what we're trying to maintain. So hemoglobin's the main protein. It's made up of this squiggle of protein, usually 2 alpha chains, 2 beta chains, with 4 iron-containing heme groups that actually bind and release the oxygen. And again, where did you get your hemoglobin? Can we say mom and dad? It's genetic, people. All of us in this room, if we're normal, will have 3 types of hemoglobin in our red cells. The predominant one in adults is hemoglobin A, made up of 2 alpha, 2 beta chains. Alpha chains are coded on chromosome 16, the beta chain on chromosome 11. So how you make your hemoglobin is encoded at conception. And it changes, it doesn't change, right? Your DNA will not change unless we do something radical to you, like bone marrow transplant, which we're doing now. So basically your DNA tells you how you make hemoglobin. There's a hemoglobin fetal, or F. Everybody keeps a little around, but as a fetus, that's your main hemoglobin, because it really binds oxygen, because you ain't getting it through here, you're getting it through the placenta. And it tightly binds oxygen. After you're born, a genetic switch occurs. You stop making as much fetal, not all the way to 0, but then your normal adult takes over. It takes about 6 months for that to happen once the baby's born. And then A2 is made up of alpha and delta chains. It's just kind of hanging around. It does transport oxygen, but it's not your main workhorse. Now, can you find out what kind of hemoglobins you got? Science is good. Anybody heard of the hemoglobin electrophoresis? We can pherese these proteins in an electric field and see patterns of what you got on the inside. You should have these 3 as a normal adult. But there's mutations out there. There's hemoglobin S, classic for sickle cell trait or sickle cell disease. There's hemoglobin C, D, E. Can I say there's about 900 variants out there? Yes, there are. Most of them benign, but that makes up the hemoglobinopathies. If I don't make enough beta chains, I make the correct sequence, there's no mutation, that's called thalassemia. So thalassemia comes in two flavors, alpha and beta. If I don't make enough alpha chains, alpha thal. Not enough beta, beta thal. So they make the correct sequence, they just don't make enough, so your body compensates by throwing other chains together. Let's make more gamma, so you have higher fetal or higher A2 and less of A. So there's no substitute for alpha. Did you notice alpha's in everything? So again, if you don't make enough alpha, it can be highly symptomatic all the way to hydrops fatalis if you don't make any alpha. It's basically baby dies in utero. All right. Remember the bone marrow. So what's the bottom line for this whole talk? If you can't figure it out with peripheral blood tests, where are you going to go? Bone marrow. That's right, bone marrow biopsy, and that's usually not primary care, but hematology. So if you need to know, that's the bottom line test for this whole talk. Again, there's another peripheral blood test we got to talk about is the retic count. Reticulocyte count is the best indicator of how your bone marrow is responding to a low hemoglobin, a low red blood cell count. What should happen if I lose red cells? The retic count should go high or low. If the bone marrow is responding, it should go high. And that's saying the bone marrow is doing what it should, but the bone marrow has to have the right materials, the raw materials to put together red cells and hemoglobin, and the retic count should go up. What if it's low? What if my red count is low, but my retic is low? The bone marrow ain't doing what it should, so it's been nuclear. The factory's broke, doesn't have enough raw materials. Sort of make sense? So the best test to really start with a workup of anemia is what's the retic. I want to know your retic count, and it needs to be corrected. I'll show you that in a minute. But basically the number's 2. If it's below 2, it's underperforming. If it's over 2, you're breaking up red cells or losing red cells. That's called bleeding somewhere, okay? So the best test to figure out anemia, first one I want to know, high retic or low retic, because that's going to tell me what's my bone marrow doing, okay? Now everybody say CBC retic. Come on, CBC retic. Say it as one syllable, CBC retic. That means you'll never forget it, because it ain't included in a CBC, so you got to ask for it extra. And the biggest mistake I would see is nobody orders the retic count, and you're always going back and resticking your patient and all that. No, you need to know the retic. So if you suspect anemia, you're getting a retic count, okay? To monitor your therapy, you're getting a retic count because it should go up if you're treating the patient appropriately. So again, red cells, you got to eat right. You can't eat Cheetos morning, noon, and night. They don't have iron and they're not fortified. So food's got to be good, got to be digested, the raw materials absorbed, taken to the bone marrow. That's where your red cell's made out. It comes for 120 days, and then it's broken up into basically by the spleen. The spleen is your bigger taker-outer of the red cell when it gets kind of fragile and old. It just breaks apart. That's called hemolysis, and you reclaim everything. So it's got a reclamation point. Now, when you break apart a red cell, guess what you release? You release that hemoglobin. And what is that broken down into? Anybody heard of Billy the Rubin? All right, anybody know Billy? All right. Billy the Rubin comes in 2 flavors on a metabolic profile, right? Direct and indirect. Billy Rubin must be directed through the liver to get conjugated. All right, say it with me. Billy Rubin must be directed through the liver to get conjugated. Let's make a rap song. If you remember that, you'll remember pre-liver is all basically red cell break apart. There's only one other thing I know that makes a high indirect bilirubin. It's called Gilbert, and they hereditarily can't process bilirubin fast, so they're always yellow. They don't have hepatitis. They're fine. They walk through life doing everything normal. It's yellow, but it's all indirect bilirubin. The other thing you think about is hemolysis. Okay, big indicator that you're breaking up red cells too fast. Okay, all the other bilirubins are the liver things. Okay, you heard about GI today? Yeah, okay, everything liver and under the liver. So you worry about the GI things. So again, you break apart those red cells, you do make bilirubin, but normally you can process it fine. The other thing you need to know about is hepcidin. Hepcidin is increased when you have body inflammation. And What that does is it blocks the absorption of iron, and it blocks erythropoietin, the hormone to stimulate red cell production. So inflammation will actually cause an anemia. It's called inflammatory block, but it's really hepcidin doing the job here from getting the iron out of your stores to the bone marrow. It basically blocks it. So just keep that one in mind. And we're looking for ways to actually block hepcidin now. There's kind of a research thing for helping those with chronic disease. All right, moving along. Let's see. Come on, red cells. Okay, the kidney. You learned from renal, the kidney makes EPO, erythropoietin. When does it make EPO? When you're hypoxic in the kidney. So the blood supply coming to the kidney, if it senses low oxygen, out goes the hormone back to the bone marrow saying, crank up red cell production. It goes right back to the stem cells and says, okay, differentiate into some red cells for me, please. It's a direct red cell stimulator, but it's coming from the kidney. Now, can we mess up our kidneys? I know you were in the renal talk. How do we mess up kidneys? Let me count the ways. Diabetes, hypertension, anything causes renal insult, you lose your EPO. So everybody with renal insufficiency, renal disease, probably is walking around anemic because of low EPO. Can we fix that? We have recombinant EPO. But again, don't go too high, too fast, cause stroke and death. So that's a big player in the anemia picture. How do people come to you? Weak and dizzy. And I love basically, this is not vertigo dizziness. I always say, when do they show up? Friday at what time? 5 p.m. is the last patient. Chief complaint, rash. Yeah, and you say, oh, good, I'm going home. No, you're not. Because they say, oh, by the way, I'm feeling weak and dizzy, right? And you say, vertigo, please. Is the room spinning? And you nod your head, yes. And they say, no, it's that I feel like I want to fall out. So you heard about how to work up vertigo. That's a good workup. Cerebellum, inner ear, yay. The weak and dizzy that I'm going to fill out, the differential diagnosis is about 5,000 things, right? You got to start at the head, go to the toe, every body system, but it's very vague. So these are the ways that anemia can present, and it's vague. I'm sorry. So what do you got to do? You got to take a very good history. Please, please, please ask about melena, remember? Because the number one place people bleed and don't know it is the GI tract. You heard about GI and GI bleeds. And always ask about NSAIDs. Why? Are people taking NSAIDs out there? Heck yeah, it's $1 billion. Somebody's taking them out there, okay, for pain. But what does it do? Well, it stops pain. I feel good. No pain. What's it doing to your tummy? It's drilling a hole, okay? But you feel no pain. What's it doing to your platelets? They ain't working, okay? So bleed, 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 bleed. So really that may be a site of where people are bleeding. So always ask about that. You got to ask menstrual history. Ask about the pica. Remember what a pica is? It's not a furry animal. It just means you're eating things that ain't normally at. Okay, we heard about that in the nutrition talk. And so it could be eating foam rubber, starch, clay, you name it. That could be a sign of iron deficiency. Poor diet, you can definitely get iron deficient, B12 and folate deficient by just eating badly. GI surgery, we're basically bypassing all the absorption of your iron, B12, and folate. Oh, gee. So we're curing diabetes with bariatric surgery, but what are we causing? Probably anemia, because, yeah, so we got to follow up on that. So, and alcohol is bad. Be kind to your liver. If somebody's had anemia all their life and the parents are anemic and their brother's anemic, can you smell genetic? A lot of genetic reasons, especially the thalassemias are very common. And have mild anemia. So make sure if it's chronic and always been stable, that's a clue you want to do genetic testing. Okay. So where do I look to see if somebody's pale? Fingernails? Heck no. People have polish, pigment, they do everything. Nobody puts polish up in their conjunctiva. Okay, so I pull down the lower lid, look for pale. If it's pale and washed out, you're anemic. The other thing I look at is jaundice, because again, indirect bili will look yellow, okay? Same as direct bilirubin. So you get 2 for 1 in about 3 seconds. So pull that lower lid down. That's my go-to. What's wrong with those eyeballs? Yellow. You need to get it fractionated bilirubin. See, is that all direct, indirect, or a mix? Spoon nails, good for iron deficiency and putting sugar on your cereal. And then chelosis and glossitis, iron and B12 deficiency. So start at the head, go to the toes. The vital signs are the main thing that tell you somebody's in trouble. So if they're hypotensive, orthostatic, tachycardic, tachypneic, what do you say? Ruh-roh. Where are we going to go? Probably large bore IVs, type and cross, and admit. Okay, that's somebody who needs immediate intervention. So you don't have time to do your iron studies. You get that later, but right now it's resuscitate. Okay, so really, when you pull the blood trigger is when somebody's unstable. Okay, if somebody's got symptomatic anemia, they're woozy when they stand up, blood pressure drops, pulse is up, you're calling blood bank and doing type and cross because that's the time to pull the blood trigger. That person needs red cells, okay, to fix them. So vital signs are highly important for you. But then start at the head, go to the toes, even a little neuro here. Oh no, what do you mean neuro? Yes, vibratory sense and position sense, because B12 deficiency wrecks your posterior columns. So that may be a clue. If they can't feel vibration, can't sense position sense, you think B12 deficiency, okay? So again, what labs do you get when you think about anemia? CBC? That's weak, people. Okay. CBC? Retics. CBC? That's good. Make it one syllable. You want both simultaneously. Remember, CBC does not have a retic until somebody in this will invent some machine. Costs more. It's an extra test, but you got to ask for it. You may want a white cell differential. Usually labs will wait to see if it's high or low, then run the differential for you. But if everything's normal, you may not need that. Get the urine, please, because why? Kidneys are important for blood cells, right? Because it's EPO producing. So if you're proteinuric, you got hematuria, that's all signs that may be why you're anemic. You want a metabolic profile. I want to know what's my LDH and direct and indirect bili. And we'll talk about that in a minute. I want to know my BUN and creatinine. Again, kidney makes, EPO helps make red cells. So get that too. And then your liver enzymes, because the liver is important for every disease on the planet, and including anemia. Okay, if they're bleeding, think of platelet count, PT, PTT, PFA. We'll talk about those in a minute. And if you smell genetic, get a hemoglobin electrophoresis. All babies in the US of A now get screened at birth for hemoglobinopathies. If you're born somewhere else or born before like the 80s, you probably weren't screened. So it was kind of hit and miss. So if you don't know, get the electrophoresis. A lot of people walking around with genetic hemoglobinopathies that never been diagnosed. We diagnosed a 55-year-old with hemoglobin SS sickle cell, never knew they had it. Very mild form. Nobody ever did the test. And you'll be amazed. Walking the streets of Atlanta. All right, CBC. Anybody ever order these in your lab? Do you do them every day? All right. So it's an important test. It tells you your red count, how your oxygen carrying capacity, what's your white count doing, again, signs of infection, and then your platelet count. Again, you need platelets for plugging up holes. So the hemoglobin, hematocrit, and red cell count should all, basically, if they're all low, you've got anemia, right? So that's kind of a clue. If it's too high, you've got polycythemia, all right? And that's not a good thing either, too. We want them just in the right range, because, again, too high, what's going to happen? Sludging. Anybody seen Karo syrup come out of a bottle? Or do you want the bottle of water pouring out? I want my blood a little watery. Keeps it flowing. What does Karo syrup do? It glops. High viscosity. What happens when you get high viscous? Clotting, okay? Clotting in all the wrong places. So really, we don't want too much, not too little, just right, okay? So hemoglobin, again, male versus female. What's your lab say is normal usually comes back. All the tests on the pants will give you normal values. Whew, okay, it's good to know baselines. All right, moving right along. The MCH and the MCHC, they're very cute. What do I really want to know? MCV. How big are my red cells? Mean corpuscular volume. This is where the money is right after the retic count. Do you have a high MCV? A low MCV, or is it normal? Okay, that's going to guide your whole diagnosis. The other one that helps is the RDW. The higher that is, the more mixed bag of big cells and little cells you've got. So you could have two things going on. Those wily patients could have an iron deficiency and a B12 together. Yeah. Two things? You're kidding. Yes, two things. So you worry about that. But otherwise, that's how that helps you. Can you look at a smear, please? Everybody know what a smear is? Has anybody ever used a microscope? Ever? Does anyone have a microscope in your lab? Ever? Can you ever get to a microscope? Well, if you can't, get the tech to do what's called a red cell morphology. Please look at the red cells because we can make a diagnosis by how the cells look, including malaria, babesia, intercellular. That's how we make the diagnosis, is looking at the red cells. So have a tech look at the smear and tell you what they see, because these are the clues it can give you just by an eyeball looking at a red cell smear. Used to be old-time medicine. It's great-time medicine. Nobody does it anymore except techs. But please ask for it. All right, getting to the platelet count. Again, this may be why you're anemic. If your platelet count's too low, what's going to happen? Leak, leak, leak. You may not be clotting. Too high? You get way high. You can get too much clotting. So again, you want to know what is my count doing. And you want to do the retic count, please. And the retic needs to be corrected for the degree of anemia in the patient. Just take my word for it, most labs will correct your retic. And they will come back with a corrected retic or, say, a reticulocyte production index. The magic number is 2. Below 2, underperforming. Over 2, you're overperforming, which is what you want your marrow to do when you're anemic. And I gave you some math if you want it. Don't throw up. It's just a little math. But most labs will do this automatic for you. If they don't, bake them cookies and say, would you please have the computer do the math, okay? Because I don't want to do it. So you want the corrected retic. And that's the one we're going to use. Please take this pathway, put it on your brain, boom, or tattoo it on your arm. This is how to diagnose anemias. This will do 90% of them for you from peripheral blood. And basically, I want to know, what's my retic doing in the patient? Once I know you're anemic, what's my retic doing? Is it high or low? So that's under 2 is low. I've got decreased marrow production. The next thing I want to know is my cell size. You get that from MCV. Is it too small, too big, or just right? It's like Goldilocks, okay? Just remember, I want one of those 3 categories. If it's over 2, I'm losing blood. 2 ways to lose blood: acute bleeding and hemolysis. And we'll talk about both of those in a minute. Let's go down the decreased production track, and we'll do that one first. Microcytic anemia, low retic count. The differential diagnosis is TICS, T-I-C-S. Can you remember 4 things? Say yes, I'm a PA. I can do 5 things. All right, 4 things to remember. T-I-C-S. T is for thalassemia. Microcytic always. Again, it could be alpha or beta. I can do genetic testing to figure out which I'm dealing with. Chronic, usually microcytic anemia, low retic count. All right, the next one's iron deficiency. Again, low iron. C is chronic inflammation. What causes that? Remember hepcidin, when you're inflamed, it blocks the basically getting iron out of the storehouse into your marrow. Sideroblastic is lead poisoning till proven otherwise. So let's talk about each of those. This is like 90% of anemias are in the TICS category, okay? Microcytic, you're going to see this all the time. So always think about those 4. The test to order in this group is iron studies. By far, that's going to be the most common thing you're going to find is iron deficiency. So do the iron studies, including a ferritin. Ferritin is what you got in the storehouse iron bank to use. Serum iron is what you had for lunch. Okay, so if you had a steak, it's going to be right up there. Ferritin, though, is what you got in the storehouse over months. So if you're low in ferritin, are you iron deficient? Say, yes, you are, okay? If your serum iron's low, maybe, but I want to know ferritin. If I had one test to do, that would be it. Okay, that's your storehouse. In this group, you get electrophoresis if you can't figure out if they've ever had one in their life. If you want to get one, because thalassemias are common, you want to make that diagnosis. If it's Flint, Michigan, even Atlanta, GA, you suspect lead, please get a lead level. Okay, we're getting a lot of lead poisoning going on in this country. Lead pipes, lead workers, whatever, and it can cause that microcytic anemia. And then a C-reactive protein or Westergen sed-rate for inflammation. Is this body inflamed? Doesn't tell you why, but it says, yes, you are inflamed, and you may be having inflammatory block. So that's how I do my basic workup for the microcytic low retic anemia. Those are the tests you want to get. All right, thalassemia, remember alpha and beta, it's genetic. You're born with it, you'll die with it, you've got it for life. It's basically your factory of either beta chains or alpha chains is not producing. And again, the electrophoresis would help you with the beta thals. You may have to do DNA testing for the alpha thals because it may show up with a normal electrophoresis pattern depending on its severity. These folks walk around with either no symptoms whatsoever, a mild anemia, but are fine. You leave them alone, please. Don't put them on iron without getting a ferritin. I've seen people put on iron, they've been on it for 20 years, now they have a new disease, hemochromatosis, and they're dying because they've got iron everywhere, and that can be fatal. So iron is a slow poison if you don't need it, okay? So please be judicious about iron, and I've seen a lot of thalassemics told you got iron, they didn't test for it. It looks like iron deficiency, so here's your iron. They go, good little patient, take the iron for 20 years, and now we got death. Okay, so please watch out for that. If they're very symptomatic, get them to a hematologist. They may need blood transfusions. They may need a bone marrow transplant. Now we're doing genetic cures. So a lot is going on with this population. They may have target cells, just like the store. You see the target? Okay, and again, so iron. This is number one on the whole world parade for anemia, iron deficiency. So what do you have? Low serum iron, low ferritin, high total iron binding capacity. That's transferrin or taxicabs that transport iron from the factory to the bone marrow. And they have no riders because there's no iron. The number one reason, GI bleeds. Please, please, if you suspect this, work up the GI tract. You're going in. Put on 2 gloves and the jelly. You're going in. You got to see, are they bleeding? Is it menstrual? Is it diet? Always say why. Why is this person deficient? And keep tracking it down. You're going to treat them with iron. They're going to get better. They should if you plug the hole or found the hole. Within 2 to 3 weeks, their retic should be going up and their ferritin should be replaced. It takes a couple months to replace the ferritin. So watch them. Bring them back and make sure you're retanking them and make sure you found where they're losing their iron or not getting enough. Okay? Chronic inflammation, again, this could be from any chronic disease, HIV, SLE, rheumatoid arthritis, Crohn's, all those can cause inflammatory block. A high C-reactive protein, 30% of microcytic, 70% normocytic. You treat their inflammation with the biologics, guess what? Their anemia corrects. So again, go cure it. Chronic disease. All right, sideroblastic. May have the speckling in the red cell. It's called basophilic stippling. So if somebody takes a look at the red cells, they may report this to you. Big clue that you got lead poisoning on board. Well, how do you get lead poison? Again, if you live in Flint, Michigan, Atlanta with lead pipes. So anywhere you're exposed to lead, that's where you want to think. Can we get the lead out? Science is good. We have chelating agents to do that. But you don't want to send, like kids can get permanently mental retardation. So you don't want to miss lead poisoning. So please, please, please screen for it, especially anybody who's exposed to it. You can get the lead out with chelation therapy. So that's your big suspect. How about normocytic anemia? The differential is normal sized. Renal diseases on here, again, for low EPO. Inflammatory block is like 70%. Will show up as normocytic, and zero production from aplastic anemia. That means the marrow is just shut down. Things like parvovirus will shut a marrow down for about a week or 2. Just stop. So those are all things we want to check out. The test we're going to get for normocytic anemia, BUN and creatinine, your metabolic profile, SED rate. Thyroid profile is something to think about too, because hypothyroid can give you a normocytic anemia. Renal function test if your BUN and creatinine are high, and then a pregnancy test, please, because pregnancy's on this list, and bone marrow biopsy if none of these pan out. So if you can't figure it out with these peripheral tests, punt and see they're going to go straight for the bone marrow. Renal failure is a big deal in this country. We heard about it from the renal talk. Janice Herbert Carter, thank you for renal. So again, it's caused by decreased EPO. Well, we can measure EPO levels and see if they're low, but if you've got a BUN and a creatinine that's sky high, you know what the problem is. And we can give recombinant EPO as a therapy. But again, we don't want to go too high too fast and keep it at a range, usually around a hemoglobin of 9. Anything above that, and those folks can get in trouble. So moving right along, aplastic. Again, this is idiopathic. That means we don't know why marrow shuts down, 78% of the cases. Viruses can do it, parvo, which is fifth disease. And again, this is somebody you may want to monitor. If you don't know why, get them to a hematologist for a bone marrow biopsy. And they may need supportive transfusions. Moving right along, the big fat red cell. This is the macrocytic kind. B12 folate are the two big ones on here. Can you say my BFF? Anybody got a BFF? Nobody knows what a B. Okay. Just think, for this whole long differential, B12 and folate are your two top contenders. So when you have big cells, big MCV, low retic count, you get B12 and folate levels. That's your main thing to get. Again, the macrocytic test, you want to get B12 and folate levels and serum folate levels. So RBC and serum. RBC is kind of storehouse for folate. Methylmalonic acid and homocysteine levels, if you suspect B12, but your serum B12 was kind of borderline. And then if all normal, think about a TSH for hypothyroidism. Last thing, if you can't figure it out, then bone marrow biopsy at hematology. But this is going to figure out, again, 90, 95% right there. What do you do with B12? Again, you have jaundice, smooth tongue, decreased vibratory and position sense. That's your clues. It's the posterior columns that don't work without B12. Low serum B12, methylmalonic acid and homocysteine levels, again, what may help you make the diagnosis. Metformin may cause this. Anybody treat with metformin? It's called diabetes. Okay, a lot going out there. Gastric bypass or PPIs can actually block B12 absorption. So think about this. The best way to get B12 probably still is the shot, monthly, to tank them up. That we have a nose spray, we have oral, but it may not be absorbed well. So think about doing the shot. And once you start, you can't stop, right? Keep it going. Then folate, again, easy to replace, easy to measure. And again, you may have elevated homocysteine levels as the cause. So again, replace with folate 1 milligram a day. Usually we see this in our alcoholic population, but also those on Dilantin for seizures or methotrexate for any other disease. All right, we're moving along to hemolysis. Big differential. The differential I have here is hematologist, because who are you going to call? Hematologist. Well, there's some things you can figure out. Hereditary and immune attack and trauma is another way to think about this. The hereditary, sickle cell, and thalassemia. But wait, you said thalassemia was microcytic, low retic. It could be a high retic hemolysis and a low MCV. Kind of crosses both bounds. So sickle cell, and again, chronic, genetic. And the one you need to know about is G6PD deficiency, because you will cause them to hemolyze usually. Unless you go out and have a big fava bean gorge out. Usually we're giving a drug that can set that off. An immune attack, again, we get a Coombs test for that, looking for antibody antigen attack. And trauma to red cells, these are really, really sick people that we'll talk about in a second. How do you know you're hemolyzing? High retic, you've got high indirect bili. Remember, you've got two types of bili. It's going to be mainly all indirect bilirubin. High LDH. LDH is rich in many tissues, very rich in red cells. So when you see high indirect bili, high LDH, your other enzymes are fine, you say hemolysis, okay? Not anything can do that besides hemolyzing. Haptoglobin, don't worry about it, don't have to do it. You may have hemoglobinopathy and hemoglobinuria. When you dip the urine, you actually get heme positive, but no red cells when you look at microscopy, because the kidney's being bombarded with hemoglobin. People who have hemolyzed all their lives, like chronic diseases like thalassemia and sickle cell, their bone marrow looks osteopenic, but it's actually been replaced with marrow. Their marrow is 6 times your or mine just to keep pace with the chronic hemolysis. So, and they would have an abnormal electrophoresis because it's genetic. All right, what tests do we do? A Coombs test looks for antibody antigen attack. Again, hemoglobin electrophoresis for genetic. Heinz body stain for G6PD. Osmotic fragility, blood smear to look at what's going on, and a platelet count again for thrombocytopenia, which will be on your CBC. So sickle cell, yes, many flavors, SS, SC, SD, SE. It's an alphabet soup out there. All these are sickle cell disease. Most common SS in the US of A. It's detected at newborn screening usually. These folks need to be on daily penicillin from birth till 6. Get all the immunizations. They're saving lives. Screen them for potential strokes with TCD screening. That's transcranial Doppler. Hydroxyurea and oral glutamine actually are saving those folks, giving them prolonged life and less complications. So we now have medicines to treat. We now have bone marrow transplant to cure. We're doing genetic cures. The first patients in the US of A were treated with actual gene therapy and are now being monitored for cure, but they're doing so much better. So I never thought I'd see that in my life, but it's happening. And there's a website for that. Yes, you got it. G6PD, what happens with these folks? Again, you give them a drug, usually a sulfa drug like Bactrim, Septra. It's got sulfa in it. These folks hemolyze pretty briskly. So whatever you're treating gets better, but they come in weak and dizzy and yellow. Okay, and you go, what's up? Is this a drug reaction? Well, it's kind of a drug reaction, but it's basically causing the red cells to hemolyze. The Heinz body stain shows denatured hemoglobin in there. You got to avoid all medicines with sulfa, animalarials, aspirin, and don't eat those dreaded fava beans. That will set it off too. So that's all you got to do for them. Immune attack, don't need to know much except if you find it, you may want help. Can I say hematologist? Because it could be either cold antibody, warm antibody. Do you need to know all that? Probably not. Just know there's an antibody attack when the Coombs test is positive. And you can look over that later. All right, parasites like malaria. Anybody seen malaria in the US of A? I've had one, yeah. Overseas, definitely. People coming in a jet plane to Hartsfield, yes, and walk right in. I have malaria. I've seen it. So yes, you get the thick smear. Babesias are the US kind of malaria. It's basically from Cape Cod. Anybody been to Cape Cod? Nobody. All right, well, if you get bit by a tick in Cape Cod, you got to worry about this one, okay? Babesia. All right, ovalocytes, and I call it basically Mike and Ike disease and beach ball disease. This is a hereditary membrane problem, and they break apart too soon. And people walking around with the red cells like this, hemolyzing, but usually stable all the time, but they have funky looking red cells. And that's genetic. When do you transfuse? Symptomatic anemia. Type and cross and give them packed red cells. Again, hemorrhagic shock, all those, and basically medical inpatients who are sick with a hemoglobin of 7 might be time to pull the trigger. A lot of studies coming back saying patients do better when they're down around 7 and transfusing them. And I work with somebody who's pretty conservative about not really pulling the trigger till really necessary. Because why? The complications, ABO incompatibility, that may be wrong label with the wrong blood, that can kill. And again, transmitting infections, we're trying to make sure that's not going to happen with testing. And there's TRALI, that's transfusion-associated acute lung injury, which we think is something in the plasma. So things can go wrong with transfusion. It's not totally benign, so you've got to be careful about the benefit versus the risk. So moving on, hemochromatosis usually comes from hereditary or too many blood transfusions. My patients got transfused a lot. With sickle cell, that may be on a chronic, getting blood every month. Well, that iron doesn't leave their body and it builds up, and it can cause damage to many parts of the body, including the liver, the heart, the endocrine organs, and that needs to be chelated and brought out. Otherwise, the patient can get really nasty organ failure. The hereditary kind, phlebotomy, basically take blood away from them. Give a pint, throw it away.